So what I'd like to do now is I would like to re-invite Josh and Rachel back up to the stage, if you don't mind, taking a little chair. I'd also like to introduce and welcome up Dr. Kathryn Fletcher. Kat, she's a Senior Research Associate at NCCRED. Come on down. Give her a little round of applause, everybody. Also like to invite Dr. Christine Shiner over down to the page. She comes. Come on down. Christine is a Senior Research Fellow at St Vincent's Hospital, Sydney, and Deputy Director of Health Equity Research at St Vincent's Health Australia, and also a Conjoint Senior Lecturer at the School of Clinical Medicine. Welcome, everybody. I'm also concerned about this red chair. It seems stable enough. So what I'm hoping, everybody, is that you'll have the opportunity to send in some questions to us. You can use Slido. There's also the chat function, I think, online. And some beautiful NCCRED people are ready, willing and able to field your questions. But perhaps what I'd like to do first is we're going to have a bit of a discussion here about digital health and digital health equity. But it's, I suppose, useful for us to understand that when we talk about digital health, we're really thinking very broadly about all the various ways in which digital platforms are utilised in healthcare and health support, whether that's app, as we've heard today, whether that's e-learning or online programs. It includes also the alert systems that we've heard about earlier today, getting information out, and then also the ways in which we can electronically support people providing treatment out there, whether that's through telehealth consultations, whether that's through education. And so really we're talking quite broadly about the various ways in which technology can support us in the good work that we do. But I suppose one of the things I asked Rachel to do, we've got two things we really want to explore today. That's not just about what makes effective digital platforms or digital ways of supporting people, but also about what role it might play in terms of health equity. And I wanted firstly to invite Rachel, if she wouldn't mind, just, I suppose, giving us what does health equity actually mean? Because I think sometimes we talk about these things and perhaps not always clear about what they actually mean in practice. So Rachel, would you mind doing me a favour and just outlining what that means to you anyway in your work?
Yeah, sure. I can give a little account and other people can jump in and
Right on.
So I guess the first thing is to differentiate equity from equality. So equality starts with the assumption of an equal playing field, and you give people equal resources and the outcome will be the same. But that assumption, I think we know, is spurious. And so health equity starts with the assumption that there isn't an equal playing field. So obviously the social determinants of health are therefore sort of really inextricably linked with their health equity framework and understanding of an approach. So, you can't have health equity without considering those upstream factors that are driving health outcomes, whether that be drug and alcohol use or some other sort of health outcome. So there's a really beautiful cartoon, I don't know if people have seen it, where you have a short person, a middle-sized person and a tall person, and the short person is given some blocks to stand on so that, they can all see over the barrier and onto the sporting field, which I think is a really lovely illustration of it, yeah.
Brilliant. Does anyone else want to make any comment about health equity in particular? I know, Josh, what was said in the video was about that experience of trauma, and that might be one of the things that people use substances for. What do you think in terms of equity or gaining access to support? Do you think that those experiences can get in the way of people reaching out to support?
Yeah, definitely. That's one of the big struggles is to actually just to put yourself up there and just to do it.
Yeah, absolutely. And obviously what came through so strongly in your work is that when you've got someone who's had similar experiences, that is a way of creating equity where you're coming together from a similar place of experience.
Yeah, because we can relate on a completely different level. We know exactly what's going on. So
yeah, amazing. Thank you. Does anyone else want to just talk at all about equity in terms of if we're talking about apps and digital resources? what do you think they can provide for us? You know, are there opportunities that we can start to look at what they could provide in terms of providing access or equity?
Absolutely. One of the most obvious things that we think of, first of all, with digital is their accessibility, the ability to overcome the tyranny of distance such that people, wherever they are, whenever they need something, can access an intervention synchronously and also asynchronously at a time that's convenient to them, such that if people have caring responsibilities, are not in a position to be able to take time off work to seek care, they can access care outside of work hours. The ability to scale digital interventions as well enables us to deliver them with limited resources that can ultimately reduce the cost of the intervention to a particular individual. So there's real potential there with scalability to reduce costs. And the privacy and anonymity that digital interventions can provide is another really important thing for conditions where people might still feel significant stigma, fear, shame about seeking help. We see that a lot even in mental health. That our digital interventions are really a safe, accessible starting point for people that may not be in a position to seek care face-to-face initially. And something that we don't think about as often, but also we've found really critical is the fidelity that comes with a semi-standardized digital intervention. You know that the quality of what's being delivered aligns with, if it's developed in such a way, clinical evidence, such that everyone's getting the same quality of intervention. And we don't always see that in the real world. We know that face-to-face interventions differ. There's therapist drift. The content of interactions is different. And also the safety and appropriateness of those interactions can differ. There was some really nice research in the UK that saw people interacting with an AI chatbot.
We will finish collecting material from storage at 4 p.m. Requested after that time will be ready for you from 10 a.m. tomorrow. Thank you.
So if you need to get your library books, everybody, sort that out, will you? Please continue.
Speaking of chatbots. And the research actually found that people from minority groups, specifically those from gender diverse communities and those from ethnic minorities that were seeking mental health care, had better quality of interactions with a chatbot than a human, because at least with the chatbot you could standardise that prejudice, biases, judgment that we can't always assume won't be there in people weren't there. So there's the capacity to use digital interventions to actually reduce a lot of that risk of interpersonal trauma as well.
Wow, that's really something. As someone who provides therapeutic support, yeah, you of course have biases, and so to think about what that type of platform might offer is really something. Does anyone else want to comment on that idea about what these kinds of platforms might offer? I mean, I think, Rachel, yourself and Josh talking about it in a way that's actually blended was really interesting to me, but perhaps you've got something else you'd like to say about the experience.
Yeah, certainly we found that the blended approach was the most comfortable, I think, for people. And when we trialled the app as a standalone kind of intervention in the community, the uptake was tricky, but particularly, people sticking with it. So the dropout from the app was really high. And I know that's a problem across the board. We've had conversations with other people who've had the same sort of issue. But it's lovely to hear your points there, because I think certainly they were our objectives in developing the app, that it was really to, there's a range of Aboriginal health services around the country that we were working with to develop the app. They have a range of access to drug and alcohol treatment and support, and so we wanted there to be something evidence-based that everybody could access. So that was one of those things, and certainly the distance was also, in those primary sort of consultations about the app, access to drug and alcohol services in remote communities is really tricky and not great. So it was something that maybe could be a little bit of a stopgap. People could use it while they were waiting or whatever. And also some of the rehab services said that they found it useful as something people could take home with them.
Yeah, absolutely. So it follows that person beyond that interaction.
Yeah, so that's true. We did find though, with some of the trying to get fill that the tyranny of distance problem, that sometimes in those remote communities the infrastructure just wasn't there. So this was a web-based thing, and so you needed to have internet access, and that wasn't always possible. There are probably ways around that, in terms of having it be a downloadable.
It's just good to have it there when you need it, because when it needs when you need help and you struggle to get it in a small town, like it's always there and accessible. So
So right there for you, Josh, and obviously too in a smaller town, that everyone knowing your business,
yeah,
perhaps there's some benefits there, I suppose too, that you can be
Yeah.
doing this in the
do
privacy
it
of
from
your own.
home. Yeah,
Yeah,
in private. Then if you don't get the help when you really want it, then sometimes it's just easy to give up again.
right on. And Kat, I might bring you in at this point when, in your experience about what works or what can be effective in terms of a platform. Are all of them created equally? I mean, in terms of their accessibility or people's engagement with them? I mean, I thought it was really interesting, Seb, talking about that idea of, being a bit familiar so that when you're doing design. Do you have any comments about what you think are some of the elements that might work better than other things?
They're definitely not designed equally. So, for example, in the app space, if you look at the apps available in the stores, most of them have no evidence base whatsoever. So there's thousands and thousands of apps that claim to help you reduce substance use, and there's no research that sort of sits behind that, with the exception of the 3 programs that we've heard about today. The other thing is engagement is a huge issue. So there are certain features, so it's called persuasive system designed features, which you can incorporate into these programs. So these are things like tracking, so helping people track usage over time, track cravings over time, and then deliver interventions at the time that they need them, like what Josh was talking about. So people describe it as having like a therapist in your pocket. So, but really paying careful attention to how these apps are designed is a really important thing, and that's not the case for what's available. And having co-design as part of that, because as clinicians and researchers, we think we know what's best, but you really need to go to the people who are intending to use these programs to ask them what is it that they need, what are the features that they would find most useful, and then involve them at every stage, so from the design through to the evaluation. And the digital programs that are out there, unfortunately, a lot of them just don't follow that process. There's no kind of best practice approach other than the digital mental health standards, which came about 5 years ago, to help sort of develop some kind of framework.
Great.
And so, any digital health products moving forward should sort of look to developing things in line with that framework.
That's very helpful, because I think, anybody who's embarking on these kinds of things, particularly as a support to other types of treatment and services available, going through a process and having it standardised is very useful. I do have a question online. So this is regarding the S-Check app, Impact and the Wadi-Wanti. What is it about the interventions that limits them to methamphetamine users, other than that are being based on some of the evidence that was presented? Do you feel like, I suppose the core of the question is, do you feel like they could be expanded to other substances or other situations? Did you want to start with that, Kat?
Yeah, I think it's really important to first tailor the programs to the specific groups and the specific substance, because there are nuances in terms of what people need and what people want. That's not to say that the general principles can't be applied. So, for example, with the impact program, so that's based on really well evidence-based cognitive behavioral therapy. And of course, we know that that's useful across a range of different substance use disorders and mental health more broadly. So they can be used as a template, but I think it's really important to pay attention to that tailoring component.
Right.
Yep.
And you're nodding there. Tell me a bit about what your thoughts are.
The same. We had lots of people ask us that, and request, and I mean anybody can use it, and there would be elements that would be useful, but the narratives and the content really was tailored around it. So to make it a more general thing, we'd need to really revise a lot of the content. But yeah, as you say, it could be a template, and there's certainly principles in there that can apply.
Yeah, and I suppose too, you've got that adjunct of being able to bring along not just the evidence base, but the peer support sitting alongside it, that sort of enhances perhaps the messages getting across and the engagement side of things as well.
Yeah.
And so if we're thinking now a little bit about what we can do to support these. I mean, the other thing I'm hearing you, Kat, saying, and I'm curious about too, is there's obviously the reverse might be true. There might be things for therapists like myself to learn about what can work for people in these through via apps or via online therapies that maybe we could be adopting into our own practices. So I'm curious about that. But perhaps if we could talk a little bit now about how we might support people. So that is educating providers, but also educating the community on how to interact with these things. Because I think in some ways, Josh and Rachel's presentation is about building that bridge between this thing that's evidence-based, but then bringing it to life. Have you got any comments on that, about how we start to think about the way in which we support people to interact with these things?
Absolutely. And anyone in the digital space will tell you these applications don't and shouldn't exist in isolation. They're part of an inherently human healthcare system, and the conduit to having these apps work for people, with, by and for people, are the healthcare workers, the support workers in the community, clinicians that are being essentially that bridge between end users and the evidence-based, rigorously tested interventions. So we see in the mental health setting, the digital service that I work in, 70% of people coming to our service are coming with the recommendation of a healthcare professional. Those are the people most likely to uptake the interventions and stick with them. So the role of the community clinicians, the capacity for blended interventions, which we heard about earlier, is really critical. And in that, as you noted, supporting clinician capability to know what's out there, to navigate consumers through this really populated market of commercial products, most of which don't have any evidence behind them. So trying to make sure that we're navigating people to appropriately safe, efficacious interventions that are rigorously controlled, and also making sure that we're providing an opportunity for healthcare providers to look and explore these apps themselves, see what they're like, get a feel for them. We found, again, in mental health research, we did some work with people in regional and remote communities about their interest in engaging with digital interventions. And it was really interesting to see that consumers who were experiencing mental health difficulties on the whole had really positive views. They were expressing they wanted to give it a shot, they were interested, they thought it would be valuable. Then we asked the healthcare providers, and we saw much more negative views of the perception of the interest and ability of the people that they cared for. Oh no, these clients wouldn't be able to engage, they wouldn't be interested, it wouldn't be right for them. So just making sure that we're not potentially imposing an additional barrier for people who might be really willing to give this stuff a try.
I think that's really interesting, and just that thing of, you know, the possibility, again, what we know can be really effective for people is, you know, this sure, that the therapeutic relationship that might be formed, but also when you're doing things outside of this sort of eyeballing, you know, some of the best conversations you can have with people is on a road trip somewhere, or, you know, walking alongside them. And so, you know, these are things that we know, obviously, from many Aboriginal and Torres Strait Islander clinicians and peers. So that's fascinating to hear. Does anyone else have anything they wanted to talk about in terms of that sort of thing?
We do over here, Suzie. We got one.
Oh, good question. Sorry.
Yep.
Sorry.
No, I think we've got something to add on. So before. Yeah.
Oh, please go ahead, Jess.
I was just going to say, as an extension of what you're saying, like, I don't think it's just about how do we make this accessible to community, but how actually do we make the service system more accessible and safe and appropriate for community.
Right
I
on.
think, whatever these systems are housed within and the departments or services, I think there's a long way to go still in making for safe community and service spaces for people to feel safe to engage.
I think you're absolutely right, and no more relevant than for people who use methamphetamine. We know that many of the campaigns that came out earlier on drove people away from reaching out for support, and that was absolutely firmly something that the system needs to take some responsibility for. But I'll get off my soapbox at that point and hand over to someone over here. Go ahead.
Hi. I'm just wondering, like, you're saying it's good to have stuff online because there's a bit of anonymity there, and I'm hearing that blended interventions are a really good idea. But say someone has a high profile job and they want to use S-Check and they've got to provide informed consent. if they use a name that is not theirs, will that matter to that process? And is any data collected from this de-identified in any way?
Thank you for that question. That's a very useful question. Go ahead, Kat.
Yeah, it's a really good point. Not all digital health interventions are truly anonymous. Like, so for example, sometimes you have to sign up with an email address, and an email address can be identifying. For S-Check, it is anonymous. We don't collect any information whatsoever. So the aim was to make it that way, to allow people from all walks of life to be able to use it without, feeling that there was any sort of risk to their confidentiality. But I think that's where digital health has a real role here. It's that ability to provide anonymous support, given that we know stigma's the major barrier to treatment seeking. But data security and privacy is a real issue. So in terms of like the development of all these programs, there needs to be really good clinical and technical governance to protect people's information. Also, in terms of the informed consent process, a lot of people will just sort of flick through that and like tick the box and whatever. So we really need to get better at giving that information in a way that is really simple and understandable, and that there are processes in place so that people know, okay, what's their data being used for, so that they, that they're safe when they're using these programs.
Please go ahead.
Congratulations on the Wadawanti app. Has group blended interventions been explored with more than one person using the app and then a peer worker as a facilitator?
Yes, actually, in one rehab service where we were piloting it in Melbourne, they did use it as part of a group program, and that seemed to work quite well as well. It's a bit of a different setting, but yeah, there's no reason why you couldn't use it that way. Have you used it that way, Josh?
No, not in a group. It's all been one-on-one.
Any other questions? Oh yeah, here we go. Adrian, over to you.
Hi. I just wanted to inquire about, do you think there's space for conversations around learnings around digital health? So design, ease of access, accessibility, transferring over to not just on human on one level, but physical spaces and architecture and geography and all of the things related to using drugs have historically been pretty horrific. And I think they are still. So it'd be interesting to hear your thoughts around maybe, hey, this knowledge that we have in developing this technology, can it be applicable in kind of broader physical spaces as well?
That's a fascinating idea, really clever question. And I think absolutely there's applicability there. A lot of the principles in terms of trauma-informed principles of visual environment, the level of stimulation in the environment can absolutely be applicable to the physical environment. We've seen a little bit of that in, I work in rehabilitation disability sector as well, and the design of the physical environment to promote engagement in physical therapies has learnt a lot from the principles of visual arts, colour, design, access to open green spaces, and the ability for environmental enrichment, both physical, cognitive, social. So I think there's lots of scope certainly to think about those principles in a digital but also physical environmental sense, yeah.
Amazing. Yeah, that's a great, I think there's what I'm hearing too is there's that real two-way thing happening, because in my mind, as an old dinosaur, sometimes you can feel a bit threatened by online things, and I just think it's great to sort of think about how it can be not just what can be produced and supported for people out there, but also what we can learn in the process of that, and certainly sitting alongside someone using an app together, I'm sure there'll be some great learnings for any therapist or counsellor in that process. And so that sort of leads me to a question more about how we can do better advocacy around digital health equity and the use of these things. What sort of advice would you on the panel give us about how we can do better to be a voice for this as a useful, evidence-based and supportive option? What can we take away in terms of our better advocacy for this way of intervening?
I think really promoting strong regulation of what we're terming digital therapeutics. Not all digital interventions are created equal, but when we're talking about these clinical interventions, these therapeutics, they should be tried, tested, safe and regulated just like any other clinical intervention. So really advocating for that and helping to identify those interventions for participants. Also acknowledging the elephant in the room that 1 in 4 Australians are digitally excluded. So continuing to advocate for social and economic policies that promote greater connectivity digitally, more affordable digital access for people who are experiencing socioeconomic disadvantage, and also promoting digital ability in the community. We know that the same groups that are more likely to be digitally excluded have lower opportunities to engage in digital learning and or work that doesn't involve as much digital interaction. So I think those social and economic reforms really trying to promote and advocate for that as well. And as people who are working and publishing in the digital health sector, being really upfront and transparent with our reporting when there are inequities, when there are not groups who are able to access digital interventions, not shying away from putting that information out there, because in order to fill those gaps, we need to be apparent that they exist and really transparent in why we need to fill them. So I think there's often a hesitancy to talk about the bad things or the gaps when people can't access digital, but being really upfront about that as a key initiative that we're trying to address as a community.
That's great, thank you. And then I suppose take the oxygen too out of the detraction of that by recognising it and naming it. Rachel.
Yeah, following on from that, the First Nations Digital Inclusion Plan tackles those 3 points, so access, affordability and ability. And I think in our experience, we can see that those areas all came up as sort of as issues, and I think I'd like to see us think about it in terms of the whole ecology around the digital apps and their development. So in terms of Aboriginal and Torres Strait Islander involvement in the development of the apps, but also in terms of who's doing the actual development, which is more of an industry kind of issue. But those companies who might be thinking about their own sort of inclusion policies. Clearly affordability. The phone companies don't necessarily want to go to remote communities, so there's obviously some investment that's required there to get the infrastructure that is going to support the use of these apps, and that's all on happening. But my recent experience suggests that it's not perhaps happening super fast.
No.
And then the ability side, I guess the apps, if we co-design and have human-centered design, then we'll make them so that they are culturally appropriate and accessible across, across different groups.
And just before we go to the question up the room, just on that, in terms of involving people, Josh, can I just ask you, when you're involved in the process of the app and all of the research side of things, what helped you to actively participate in that? What was useful in sort of being involved in that, being involved in the videos? Were there things that we could do better to ensure that people feel like they can participate and contribute?
No, I'm not really sure. I don't really know.
So, I mean, did you feel, I suppose my question really is just around whether you felt supported to be involved. Yeah.
It felt really good to be able to help out and be asked all these questions and then to actually be heard.
Right on. Thank you. Up the back.
I'm really glad that you guys were talking about the fact that there is not always complete access to the internet throughout the country of Australia, because when we talk, this panel talks about the equity of these apps, that it really increases the reach of different health services. However, it's still almost a one-size tool that goes out. With the example of equity, that it's based on different people's needs. I'm curious, what would be one feature or update you'd like to see in your app that you think would help to make it more equitable for additional people or populations? Like, there's always something that can be added, and I'm curious what that one feature you really wish that you had with it right now.
Maybe I'll start with you, Kat. Just in terms of your experience with the current apps, are there things that you might, looking back, might want to tweak slightly to think about? Is that?
I was not with these ones, but Cracks in the Ice, which is crystal clear. So that's a really nice evidence-based program that's out there for methamphetamine use. One of the features that they talked about was having offline access in their app. So their app sits alongside the web-based program, but they're very aware that people in rural and remote areas have pretty bad access. And so just a simple thing like that, having that offline access means people can access that information at any time, regardless of their connection issues.
That is a really good point, yeah, so that you're being able to access it without the internet, because often it's dropping out and you've not got coverage or you haven't got the data. Well, these are all the other equity elements that you're talking about. And just in summary, as we wrap things up here on the panel, I'm just wondering, in terms of research, what do you feel like are the next big things? What would you like to see us delving into with regard to digital health? What's on the top of your list to try and explore? I might start with you, Kat, and come back down this way.
Yeah, so as I said, the evidence base is not necessarily there. So mental health's doing really, really well, and we have a lot to learn in terms of developing programs for people who use different substances that we need to make sure that these tools are safe and they're effective. So the studies are good in terms of they involve people in the design, they're acceptable, they're feasible, there's pretty good uptake, but then they don't go to the next phase, which is, does this actually work? So are these achieving the clinical outcomes that we would expect and align with the goals that the people who are using these programs want to achieve? Getting that evidence base in terms of the clinical outcomes, making sure that we are recording adverse events. I don't think we can assume that a digital health tool doesn't have adverse events. And when you look at the literature on all of these programs, it's pretty loose in terms of reporting that stuff.
Okay.
And I think there are so many opportunities in terms of the big data that comes from this. So AI, it's here. There is so much potential in terms of AI-driven chatbots that can triage people into services that they might need. And again, like harnessing that data to use ML models to predict relapse. So the area is ripe, but we do need to be very careful in terms of data security and privacy. But I think the main thing for me is, what are the outcomes? Like, is it doing what we expect it to do? Yeah.
Excellent. Christine, did you want to add anything to that in terms of next steps for research? What do you think? What's on your wish list?
Yeah, I would absolutely agree. Something we hear often is digital health is a field that's got more pilots than Qantas. So as Kat alluded to, we see an enormous amount of studies that focus on the development of the fancy new shiny product, a small pilot to say people like it and it worked in 2 people, and then it falls off.
Right.
And what we want to see more increasingly is the maturity of evaluation. Things are rolling out to clinical trial, to large effectiveness studies in the community, and then implementation studies, really looking at how these become part of the broader human health ecosystem. How are they being used by health professionals in the community, by consumers in the community, and looking at the socio-technical constructs of this field, the human factors, the behaviour change, the stakeholder engagement, the co-design. So more than just focusing on that initial technical development, it's all those other human elements that I think are really warranting more investigation.
Fantastic. Rachel, what do you want to have on your wish list?
I think there's huge opportunities to do more research in the Aboriginal and Torres Strait Islander space. It's a really there's some fantastic programs being developed there. Menzies have a really good sort of digital health First Nations space, which is really, really great to see. But I think there's plenty more work to ensure that access is available across the board, and that First Nations communities are really getting the benefit from the field. Yeah.
And just finally, Josh, if you don't mind, just one little statement from you. I'm just curious to know, in your work as a peer and lived and living experience worker, what do you hope? What would you like to see happen next for people like yourself working alongside those who might be experiencing concerns with their AOD use? What would you like to see?
Just more First Nations lived experience, paid roles.
Yeah, absolutely.
Yeah.
Excellent. So, and that's really what equity is about, is fair pay for fair work. Yeah, absolutely. Could you please join us? What an amazing panel. Thank you so much for your input today. if you'd like to return to your chairs, I'd like very warmly to welcome to the stage legend Professor Nadine Ezard to give us some closing remarks and to say thank you to her for her amazing leadership of this incredible enterprise. Please join me in welcoming her to the stage.
Thanks, Suzie. You've given me 1 minute and I've written 2 pages. Oh, no, yeah, that's right. Everyone's still concentrating. Thank you. Thank you for coming, and thank you to all those online and to all the people that are still here in the room in the dark on this beautiful Friday. So really glad that you stayed around. I will truncate what I was going to say because it was going to take 5 minutes. I do need to thank, though, a few people. So I want to first thank Uncle Michael West and the Metropolitan Land Council for welcoming us to Gadigal Land, and to the State Library for hosting us. Thank you to all of our speakers, local, national and international, especially those that travelled to be here and stayed up late at night to speak with us, and to our chairs, Stephanie Janitas, Brendan Clifford, Suzie Hudson, thank you for keeping the energy up. Thanks to the organising committee, Dora Caravazzalis, Harriet McDonald, Sophie van der Helder, Seb Bed, Ed Broadbent, Brendan Clifford, Jack Freeston, and especially Gemma Halen and Andrea Delgado. And last but not least, I need to thank the NCCRED Advisory Board and consortium members, and to the chair, Ingrid Van Beek, that opened the session today. So we had a couple of themes today, you will have noticed. So the first theme, we were drawing on learnings from Europe, UK, New Zealand, and from hearing about where we are in Australia. We discussed options for the future with respect to early detection and prompt response to emerging drugs of concern, with the aim of promoting health and wellbeing in the community. I won't run through the individual presentations, most of you are here, but a number of key points emerged from this session that I just want to reiterate here. So the importance of community engagement and connectedness in the whole project of detection and response, and the focus on the system, not just the alerts, so that we're going towards a prompt response system embedded within relationships within health and community services, for example, needle syringe programs, as a component of the system and not just a means of communicating the alerts. And the need to clarify the range of audiences and means of sharing information that would include low literacy, non-IT connected communities, and actively socially media engaged and experienced people who use drugs. So just making sure that we are engaging all those different kind of communities with working up what we're doing going forward. And really, and this theme came up twice in both sections, is the importance of credibility and trust. And this really underscores the key role of peers and people with lived and living experience. And the last two elements for the prompt response section were, we do also need to look at technologically facilitated lab analytical capacity, internet-based trend